started this program back in 2017. At that time, in the state of California, if you had public insurance or Medi-Cal, to get a continuous glucose monitor, you had to have 1 month of data showing you'd poked your finger at least 4 times a day to be able to get a device where you didn't have to poke your finger. Policy hadn't caught up to the reality of new technology. So we knew when we started this program that we were going to need to fill in some gaps because there would be some children who got diagnosed and were able to get insurance approval right away or very quickly the first month, first week even. We also knew that there would be some kids who would not have that. So we wanted to have an equitable program so that everyone could get this, also to have a safety net. So we were able to get philanthropy for that. In parallel, though, we also were advocating with the state of California. They had a group called a technical advisory committee to advise on diabetes technology. And so a few years later, CGM is approved for all people with type 1 diabetes. And so other examples of that, the entire country of Australia, gosh, it's probably been 5 years now. Same thing, universal coverage for continuous glucose monitoring. And they have very dramatic data showing how that improved outcomes for people with type 1 diabetes. So we needed to work on parallel tracks, but the good news is now everyone has access to continuous glucose monitoring. So sometimes it takes a while for the policy to catch up. So then the question is, can we keep doing what we're doing? Can we sustain it internally? And we're working on that right now. And then we're also working with the Type 1 Diabetes Exchange, which is a large registry quality improvement consortium across the US, to come up with a research protocol to try to scale up a version of this to other clinics who are interested as well. And so that's probably going to take a couple of years of working on that. But the goal is, can we share what we've learned and can people adapt it to their own clinic in a way so that all children with type 1 diabetes can get better outcomes. I would say the teamwork's the most important part of it because, it's hard for us all to change, right? And so if the team's not on board with changing, and the good thing is now we can point to our data in the Nature Medicine paper and say, it worked. And now let's figure out how we can adapt this to your program, to your situation. But the team's got to be on board with it and then be willing to change how they deliver care. And there also needs to be some support for that initial process of changing how you provide care, because that's extra work to change what we do. And then as far as the TIDE dashboard, we're working with a nonprofit company called Tide Pool to take that dashboard system and have it available in their available product. And I think they reach about 400,000 people with type 1 diabetes, have their data that goes in through this. So we developed that TIDE dashboard internally with our engineering team, but you can't hold it. Graduate students can't hold together a technical component that's going to scale out to other people, much less even long-term internally. So that's one solution for that technical challenge, is to partner with a group who does that.